What you reading there, Jim?
Life magazine.
Nothing but the best.
1938. I mean,
Show me the cover. We keep the latest, greatest magazines.
yeah. This is even before me.
Come on back. Today we're going to start the second process.
Okay.
We're going to take records. We already have a picture.
All right.
And we already have had you look at the sum total of the questions that people have come in here before. And so today we're actually going to move forward with treatment.
Okay.
Started when we took the information, but now we're going to start taking some records of what is. So come on back and we'll get that started. And Jeremiah will take his position.
Okay, Jeremiah.
He's left his service vest on the rack. That means he's on break.
Okay.
So the purpose of today is to get some photographs, to get some postural views, and also to record the situation in your mouth, and to get some basic vital signs that we can then see change as we're working.
Okay.
And if we didn't have those, we wouldn't know where we started from.
It's a baseline today.
Yeah, it's not good or bad, it just is. That's just what you have.
Okay.
So while you're sitting, I will show you how we take the impression. We use some basic stock trays, and then we use a putty, put in the tray and have you close. So I'm going to fit the tray and make sure it's your right size, and then put some putty in there and have it closed down. And then we're going to put a little liner in that to make it extra specially accurate. And then we're going to put it in this box and send the information to Great Lakes Lab for printing of master models.
Okay.
And that also goes into your chart, and at the same time the digital record, and at the same time we're going to go on and pour stone into the model so we have a working model. And then we're also going to get a bite registration. And I'm tired just thinking about it because the tray in. And are there any sore spots or ulcers or anything we should know about? Okay, so I'm just going to try this in gently. Put it here. Poke just a little wider. Okay, and then set it down. Now, did that poke or prod anything? Did you feel like on the tongue side some rubbing?
Not on the tongue side.
On the cheek side?
On this side and the bottom right.
Okay, I'm going to try it again.
Okay.
But let's look down here and see if there's anything. Just down in that area? Or inside, right there? You got some knots inside of bone. And that's very diagnostic of clinchers and bruxers. I have some. And it's buttressing of the bone in response to the clenching. You know, when we go to the gym and we pull that weights, the muscles pull on the bone and causes it to get denser. Okay. So you've got some extra bone there. Good hard head, never hurt anybody. But it's a sign of a problem. Okay. And the body's trying to help get that tongue into place and not break the bone. So I'm going to try it in one more time, a little more gentle now that I know that that's down there. And so when we put the putty in there, you can close, but be very careful. If you feel uncomfortable, just stop. We'll go to a larger tray. So we'll try it in one more time. All right, that's good. And if I just went that far, you'd be all right? Okay. Then let's do it just that far. So we're going to dispense.
I mean, it wasn't bad.
Yeah.
I just felt...
Well, no pain, no gain doesn't work. So just keep in mind that we're here to make you brag on us.
All right.
Actually, it looks a lot like pistachio ice cream, but
it does.
Yeah, it's not.
Is it?
But it's putty. It's soft, and we'll just get you gently closed down on it. That's good. And rest your teeth, bite on down into it, and gush it right there. That's all you need to do, Jim. You're great. Give you some tissue. It actually, inside there, the autonomic nervous system, food. Got to get some spit in there. So sometimes people notice a little more spit. This has a setting time. I'm going to take a little sample off here and watch it. It gets set. And, okay, so what I just done is while I was waiting to see, I don't have a timer. I just reach over here and get a little piece of this material and wait till it sets.
Okay.
If it's set here, I know it's set in your mouth because of the body temperature. That's an impression of those knots.
Okay, wow.
Those are called tori, so there's a bunch of them. If there's one on the roof of the mouth, it's called a torus. We're going to then trim this just a little bit and put a wash in there and stick it back down. We also take a top and a bottom, because the only way you can do this is have the upper arch and the bottom arch.
Okay.
In considering where you're going to put the contours and what's going on up there, it tells us a lot about your problem. So I'm going to try to train on the top, but I'm also going to reach up here and see if you got a torus up there. It's a little narrow. Some buccal tori. Big one there. Okay. These are all little hints. Okay, I'm going to see if a smaller tray will work.
Okay.
Your wife says you have a big mouth. I'm afraid you use this tray. So should be armed with evidence. Let's try the smaller one.
Okay.
Okay. So easy does it. Don't bite down. I think I'm going to try the smaller tray. Did it bump the knots?
No.
Okay. They're like little projections. Instead of stalactites or whatever they are hanging down, these are just sideways. They're
Okay.
a ridge, so they probably will scrape a Dorito on it. And, I mean, they're really bulgy, so sometimes a little sharp toothbrush even will scrape them.
Okay.
So, this is a scannable impression material, both the putty and the wash that we're going to make, so that we can put it in that box. Put your chin down, just bite into it, gush into it. Okay. Are you okay? All right. Hurting anything? Yeah. Some of those teeth that you're going to have restored won't be there later, or be the same way. I know we have some extractions and some large fillings, so you can actually feel this stuff. It's going to tell me when it gets firm. And so basically it's doing that in your mouth. I noticed the tray kind of came forward, so I might use the bigger tray to get a little farther back. We'll see. Starting to get solid, but not firm enough to take out. Are you okay? Okay. Squirt. This needs to be repaired right here, and we have it in putty form. So if I was going to use this impression, I might add a little bit back here, but I'd rather have more in the tray, so I may not use this one. I don't throw it away, because sometimes that's the better of the lot. But I'll take a little putty. I've got to go next door, so we'll wait just a second. Don't go anywhere. Yeah, that was good. Oh, you can tell your wife made a good impression. Yeah, what we're doing is recording the way things are before you even have your down work done. And where you can even make you a starter appliance, kind of a trial appliance. And even with that, you'll notice a big difference. I'm going to have to go next door and get the parts.
I'm really excited about that.
Well, it's good. So am I.
I'm looking forward to this.
Okay. So we're going to take this is Jesse, my lab man. He's going to take that down and just trim out all the interproximals and any real big excess there is in here. So he's going to trim this up just a little bit. He's going to leave the posterior extensions, but just take a little off. Just that one, really. And a little bit there. So basically when we come back, we don't have anything that's going to be knocking around on those bumps. Where we can do our best is to make sure your heart stays good, the AFib goes away, Lord willing, and your blood pressure comes within normal range, and you start feeling good enough to get out, burn a little of that excess adipose tissue off, and then basically it's just a complete reversal. But that's we're looking to immediately try to get you to a point of optimizing your condition rather than letting things deteriorate. That's a big drain on your system as far as the amount of periodontal and periapical infection that you have. And when Dr. Zane cleans that off and cleans it out, you should notice a big difference right then. But with those teeth missing, then we've just created another problem. So what we're going to do is actually optimize your situation so that when you have the teeth out, we have an immediate type of appliance that can go in, keep your tongue from getting lost in the back of your throat, and be able to restore even better the relationships between the tongue and the teeth and the tissues. It's very difficult for that tongue when all of the goalposts that it's been used to using disappears. And so we're going to optimize things by not letting you go any length of time without the structures that would keep your tongue in the right place in the right direction at the right time.
Okay.
So it hadn't been perfect, but we could make it a lot worse by just pulling things out, fooling around with
Okay.
and we will give you something to eat with, so that when you take it out, you don't have all those missing teeth.
Okay.
So while we're waiting, Jim, we're going to take some postural photos.
Oh, okay.
Come on up, have a seat. You're going to stand, kind of line yourself up with the thing. You don't have to put your head way back, just straight.
Okay.
Kind of line up with the middle.
Over there. That just reminds me. David bought my phone so I can send those pictures to
Oh,
you.
good. All right, you're looking good. That's great. Very photogenic. Lined up. Then I get you to turn facing the, but lined up with the middle line there. That's good. Just stand there. Gotcha.
Spot. This. Just gutting out the interior. So when he puts that other liner in there, it'll be a pretty daggone good model. So that's
You
all.
are making more of a canal like?
Yep. That'll be more of a good impression there. It's all gutted out. So when he puts the other liner in there,
Okay.
there won't be any
So the impression is not being made out of this. It's the liner that's going in that's going to make the impression.
yeah, this is a custom made.
This is just a tray.
Yep. Customizing the tray.
Okay, so the impressions are not going to be made out of the green. It's something that's going to go in there.
Are gone because the top is got a little void in it. I'm gonna put that some paste on that, and I'll show you how I do that. We have these containers, so we mix them, and we are using a scannable material, but you have to mix it and get it even. It can't be blobbed together and not thoroughly mixed, and so it's a function of time. And it sets fairly quick, which I like, because if you have people that have a little hypersensitivity in their gag reflex, you get it before it's a real problem. So I'm just going to set that here, guesstimating about where the palatal should be, so I don't have to use so much of the wash material. It has a pretty high arch, so I'm just guessing that's about what it's like. Put this back in, imprint it. Sorry, Jim. Go way back in here. There we go. Putting that in just a minute, not as long as we did before. We're just getting a rough fill of the top. Very patient. I got my fingers out there in case he wants to bite me. Okay, let's take it out. So we've got enough there to smooth it off. Here's some tissue for you.
Okay.
You should get any little bits and pieces. We'll kind of take the excess off. There's a little place here that we filled up. So we're going to do this on the lower, but I'm a little worried about that being in the way. So I take a number 12 blade and just kind of smooth off the extra impression material, so you'll have a good experience and nothing with poking. So that looks pretty good, and the other one's good. So now we're going to put this in. It's a wash, and I'm just going to fill that with the regular impression material, but the putty that you saw me fill in the top could have been used to fill that in, make it a little more perfect. There was a little bit of probably interproximal stuff there, so I'll clean that out well. So just get the sides all filled with this, and where those tori are, and get this dispensed. And this is also scannable. I do that because if you miss a spot with your wash, it's not going to be a black hole in the scan. So it's both being scannable, it works real good and efficiently. So
this looks like the fun part.
oh, it is. Yeah, this is better than the other. I haven't pulled any teeth today. All right, you can bite that down. Yeah, are you comfortable? Okay, don't bite real hard. I mean, I don't want you to hurt yourself. Hold that. In case you get you down, I'm going to actually give you a little mouthwash you can swish around and spit. And that will give you a little better taste, only to do it again. So we've got some floss for you if you need that out. There you go. Got moisture there. All right. Very good. Well, I'm going to give you an A for the day.
Okay, I'll take it.
Yeah, that's nice. So, I can't stop now just because we didn't video it. All right, close. Good. While I was dispensing it, it seemed like a lot of wash, but we were able to save money and time by having that interior filled up as much with putty as possible. It's a more expensive impression than we usually take, but it has the advantage of scanning. It has the advantage of multiple impressions. It's very flexible, so you can pull a model out and not tear it apart. And I like to do the repairs and customize the tray. So when we get to the wash, you know, it's just so simple. It's not one material, and you have to get it or not and take it all over again. So we've got both. We're going to just keep this aside because in a pinch, it's half of it's done. So we use single-use floss. We don't reuse them.
That's good to know. We appreciate that.
Yeah, thank you. But we buy that in large quantities. If we get these from Shine.
Can I take this off to do?
Yeah, it seems like that would be counterproductive. We don't put this pulse oximetry on the finger that we do the blood pressure, so that when we put the blood pressure up, it doesn't look like the patient quit breathing on us. So it's just a little, we're going to put some wrist clips on for doing EKG, and we get a whole bunch of information in one fell swoop. You get it? Have this floss, find some more. So basically what we do is I spray his wrist so that the electrolytic light fluid will touch his hairy arms and make contacts with these clips. I don't, this wrist clips, non-invasive, and for the most part for what we're doing it does just fine. So basically we're going to get a blood pressure because there's nothing on this tape yet as far as blood pressure. So regardless while this thing's getting set, I'm going to change the leads, and we're going to go over that in a minute about which lead to use for starters. If you get a blood pressure pulse and oxygen, you're doing more than most dentists. I got them on the wrong one. See how that's upside down? It looks a lot more normal when you do it this way. The white goes on the right. All right, but this is the way it's supposed to be. That's a QRS wave, and this is a SpO2 wave, and we're going to talk a lot about that, but right now it's searching for blood pressure, so we'll see what happens after quit squeezing the arm. It's not a really true thing, but it's all right. It's 136/90. He does take blood pressure medication, and now the air is out of the cuff. His pulse ox looks pretty good, and so what I'm going to do is print it. And basically, I have a book that helped me. I picked it up at one of the bookstores. Barnes & Noble probably has it. It's just for physicians. It's got everything in it. You ought to start looking at hearts, because basically you're affecting it every day with your dentistry, whether you never know it or not. So now we have a strip, and it's like a little scroll. This thing's hard to work with. So before I do anything, I'll take a minute and put his name on there. And then I put that this was without, obviously he doesn't have anything, but later I'll be doing strips with an appliance. So I want to see what this thing looks like before I start messing around. And sometimes you pick up things that you wouldn't ordinarily pick up, like his blood pressure is excessively high, or his pulse is excessively high or low. 80 is about optimum. 56 is not good. He doesn't get his blood out to his extremities. He probably has cold hands and feet, or a lot of people that have low blood pressure do. When you stand up, blood's not out there where it's supposed to be. You can take a spill. So too little water or too much water is bad for you. Too low blood pressure or too high blood pressure, it's bad for you. It's kind of a myth out there that says the lower your blood pressure, you're going to live 1,000 years. You're going to have cold feet, cold hands, and poor circulation. So I have a little cup hook. I just stick over here and nail it. And then Joan comes in after I'm finished with a stapler and staples them all together. And then I have a dental EKG stamp, not for diagnosis, and stamp it on there because I don't want anybody to think I'm doing cardiac stuff. What I'm doing is balancing oral function, and I'm using this to guide me as to how to balance oral function. And you'd be surprised how much easier it is when you have the assist of an EKG. You can still do blood pressure and pulse, because when you're affecting the blood pressure, usually, or the pulse, it's the pulse that usually is the most predominant one, then oxygen goes up and high pulse rates go down. The reason is the pulse is up is because there's a lot of adrenaline in there trying to get the blood around faster and faster and faster. It doesn't have a whole lot of oxygen in it. So if they're down around 93, 94, usually the pulse is way up. And sometimes it's the blood pressure that's way up. In his case, it is up, but it's up higher than normal, but it could be a lot higher if he wasn't taking medication. And we've had a conversation about if he's taking medication and he's got an appliance in, and the appliance is getting him more oxygen, then his blood pressure may start descending in spite of the medications, and he may take it down to a place that really is scary for him and anyone that's around him, and end up in the emergency room for no reason other than that he should have talked to his doctor about minimizing his dosage or working with him on getting off the blood pressure medication. It's not unusual to change blood pressure 10 and 20 points without anything other than the appliance. It takes a while to, work into that, but it can be done, and we do it regularly. And the pulse is another one. Somebody has tachycardia or a very high rate, and you give them some air, all of a sudden the tachycardia stops. I was with a guy at dinner in Tacoma, and we were taking a class, and one of his patients called him, and she was in a rural hospital with a nurse friend, and her tachycardia was like twice what it should be. Instead of 70 beats a minute, it was like 130, 135. They tried to get it down. They were worried she was going to have a heart attack. No medicine would touch it. They wanted to transport her to another hospital and give her a pacemaker. And the nurse that was with her, kind of alternative, said, hey, we were at your class, this other doctor's, and you said something about this affecting fast pulse rates. Is there anything we can do? And he said, sure, yeah. He said, just get yourself a Kleenex and tear it in half. Very complicated, or just make spitballs. Good fat ones. Chew them up, put them on between the teeth, push your jaw forward, and call me back in 30 minutes. And when she called him back, she was checking out of the emergency room. She just got some air. Her body was really letting her know that she was in respiratory arrest, essentially. But so what we are talking about is very serious stuff. It's something that we should be aware of. When you lay that patient back in the dental chair, that tongue goes back there, they're not scaredy cats. They're choking, and they don't know it, but it's not the same. Their blood pressure's up, their pulse may be up, or vice versa, or both. And it's the adrenaline. They're just trying to, in the fight or flight. So now we're looking at the baseline for Jim, and we're going to talk about later in a more advanced course. There's other settings that we need, so I'm going to change it to the waveform for lead 2, and basically that little arrow up here is now our designations for Roman numeral 2. And just ignore it. Jim just had a cardiac arrest, and we'll try to get this off camera, but it's just resetting. It will go away. Come on, Jim. All right, stick it back in.
Oh, okay.
Okay. So we'll go to lead 1 just to make sure he's all right. So that's lead 2. We'll go back to lead 1. Get this back up. There we go. So that looks good. So you can check your instrumentation, and we'll go back to the lead 2 and see why that was squawking so much. Lead 1's nice, lead 2's not nice. Alright, let's go back to lead 1 and cut it off just a minute and see. It's 25 per second, that's good. Pulse is low. Get rid of this and get. So, lead 2 is, we're going to discuss that later with Nurse Renee, and there are some things about these waves that could improve. There's called a diacritic notch in the length of this out, and the ripples on this line. And the good news is all of that's affected by what we put in his mouth or don't put in his mouth, or what he doesn't have, or what he does have. What he has is some broken down teeth, and some are going to need to be extracted, but we want to get everything where he was before we started rearranging the furniture. So basically his pulse is 60, his oxygen's 95, and all these values go up and down as you're taking them. It's not just one static number. It's you can take them in real time, and this will change. If the patient moves like he just did, you're going to get some really funny looking stuff up here. Some of you use this all the time.
Go ahead, move again.
Move your hand again. See how it gets all out of kilter. Now when a patient has a shift, when you put something in and all of a sudden you see all that scrambling, we've got that captured for you and we'll explain that. That is a positive rather than a negative usually. So I would say you're going to need to look at vitals, but you don't necessarily have to have a sophisticated piece of equipment if you're not taking blood pressures on every occasion before and after, and pulse and oxygen. Well, that's a good place to start. That makes it safer, and you have documentation that the patient was probably better before you seeing it. And if you're doing general dentistry and you put a crown in, it'd be nice to pip that baby up and see if it's blocking the tongue or in the wrong contours, and checking your work. Partials, dentures, we've done that in the past, but we've never done it connecting it to the rest of the body. It's just there's going to be a sore spot. Now we're in the game as far as looking after the patient, doing it safer and more fruit for the patient and for you. So right now it fluctuates between 50, 51, and it's gone up to 96, and it'll go back down a little bit and it'll go back up. And so you see a range more than just one number. But did you take your meds today? Mm-hmm. Good. And you take it at home any particular time?
Usually 9 o'clock in the morning, 9 o'clock at night.
Good. So he's being responsible and taking meds, and I told him if we put an appliance in and those numbers start changing, which we usually see an effect on the blood pressure and the oxygen and the pulse, he's to share that, and with his doctor and with me, and not let the effect of the appliance be so great that the medications haven't been regulated by his doctor. A lot of time they give them permission to cut their dose a little bit as they start seeing those numbers disappear, but I never do it myself. Even on a CPAP, that's by prescription and a doctor has recommended it. So Jim has a CPAP, I'm not going to tell him to try the appliance. I'll make him a nighttime appliance for daytime, because nobody's covering him during daytime. If he's at work and takes a nap, then he's just without something. If he's got his other appliance that we make him for night during the day, he can test it out. We had one Boy Scout leader that was on restriction by his doctor for no dental appliances, and he wanted to go camping, and they don't have an electric plug where those guys go camping. So he got permission from his doctor to at least get an appliance, and then they would test it. That's the right thing to do before he goes trying to see if he's going to have a cardiovascular accident or something. So sure enough, he tested him before. He had 125 apneic events per hour, and I didn't get the figures for, they were using an auto-PAP, I think. He really had some serious apneic events, and that's why he was on restriction, no dental appliances. But he begged him, he said, I'm a Boy Scout leader, at least I want to go camping. So with the appliance that we put in, a half of an apneic event in an hour. He took him off the auto-PAP and just had him continue to use the dental appliance. So this is unbelievably powerful. What we're doing is, this is on lead 2, and when you're working with Renee, she's going to want to see lead 2, that little number up there, and then there's a way to change it. On this machine, it quickly converts over. And again, I think I was talking to you, this is evidence, tape, good documentation of before you touch the patient, what they've got, and the effect of what you did on their health and well-being. So we're going to now do lead 1. Looks a little different. It's as the tongue is coming in the mouth. Lead 2 is when the tongue gets past entrance into the anterior, towards the anterior. So now what I'm going to do is run lead 1. So we've got both leads, pictures, a CEF, functional questionnaire, and we've spent a lot more time with him than anybody in medicine has, because their time is very limited. So we can be a very a safety net for the patient, the doctor, and myself. We're working together. They're helping us and we're helping them. But only a dentist can do what we do as far as the appliances and the treatment. So we better be working together. We can't do it all by ourselves. That's really reckless. So we've taken the blood pressure, the pulse, and the pulse is on the lower side. It can go down below 50. It was just a 49. We started doing appliances. The skin temperature could be a sensor from our equipment could be placed on his feet, and you can actually measure the skin temperature change. Most of the time they just tell you, man, I don't have cold feet anymore, or cold hands. The pressure being low can do that. The oxygen is, the pulse rate is slow, and so it's probably some of the medication you're taking. I don't know, you take anything for the heart itself, for the AFib you do, right?
Yes.
Okay, so some of this may be a part of the medication, and we want to share what we're seeing with the doctor so he can adjust everything. I had one the other day, was a cougher for 6 years, and she went to Mayo Clinic, and everywhere her husband heard me give my testimony, Christian businessman. So she was introduced to me by her husband, and long story short, the EMT had her on Neurontin. The Neurontin is also known as gabapentin, is highly addictive, and she was hooked. And so one day when she was here, she's having a coughing spell. We adjusted her clients using the vital functions, and at 10 o'clock we tuned the cough out. So I quickly called him and wrote a letter and documented that had by accident happened, but would he consider the other 2 feedings that I think it was like 10 to 4, I don't know, 3 different times. So we had a deal that when I got her off the drugs, she'd bake me a chocolate cake. And so I was really praying he would come across with the goods, and he did. He told her how to do it, and she had some withdrawal effects, but we had great success getting her off the medications by adjusting the appliance at the time she needed the drugs. So you have to work with the doctor. Some guys are hard to work with, but you do your dentistry safely, and you inform them with letters or emails, document that you're communicating, even if they won't. and suggest maybe they find somebody else that will communicate. All right, so the things we are looking at are very subtle. This machine does not have a filter on it, so some of the activity that I look at and use to see how well our appliance is filtered out in most other equipment. You can get it unfiltered, or you've got a switch on some of them. You even switch it from filtered to unfiltered. I'm very interested in the subtle changes. And again, I stamped these strips with, this is a dental OSB EKG, not for diagnosis, so that people understand I'm not treating. It's very close, 131/75. It's not too far off. We're going to get all of this information before we start. It's very important. It covers your backside, and it also covers the patient. It also gives you information to communicate with the doctor, and they're very impressed by that. They probably never had a dentist be that attentive. Now, the next visit will be basically dealing with the delivery of the appliance. The sequence is: first visit's a consult. It's free. There's no obligation. It's loaded with information. Many times, like Jim, they decide to go on and do it. So that afternoon I could get records, and the next morning I could put it in. So we have all kinds of ways from a practice management standpoint to take advantage of the patients. Half my practice is from people out of town. I mean, Canada, Florida, different airports available around us. So it works nicely to have somebody come in, spend a week. Other people, they're working and they get a day off, they want to see something in the morning, and then if they we have a spot which we usually kind of try to hold for getting some records so that we can get this thing going, and then next time they come in, we deliver it, and we see them shortly after that. You're going to hear this over and over again. They're going to shift. We want to catch that shift. It's not the plastic that changes, it's the patient that's changing. Hard to understand that at first, that you're actually expecting all of this stuff to happen, but it does every time. It's just the way the good Lord made the body. It's just like the sun coming up. You're pretty sure that globe is going to come up over the horizon. It's going to come from the east and set in the west. So what we're doing is very predictable. It seems a lot, but after you've done it a couple times, it's see one, do one, teach one. You know, you get your staff on board, get a couple of them feeling a lot better, you're feeling better, you're going to change the world. And so we're doing this before Jim has any work done, because we are going to change a lot in his mouth, and I'd like a baseline. We're going to actually make him an appliance. Jesse's waiting to finish it up and get it delivered to him. We'll go through that with you too. So the sequence of events is that we know what symptoms he has, how he's doing, and we know his vitals, and then basically we put the appliance in and see how we're doing. Gesundheit. Dog just sneezed. So the deal is that its dentistry is its best. It'll just get better. I'm sure this will change in time, and we want to change with it, but I just want to share with you what you can do, and the patients feel it. They know that your heart is to get this situation as best as optimize their function and activity, that how they feel, how they sleep. It changes their whole life. So you end up with a different relationship than I've ever had with my patients, because of the way that you're actually affecting the whole picture for them. All right, so we've taken Jim's vitals before we actually start doing work, and I'm talking about the general dentist doing extractions, surgery, all that stuff. And that's going to change things, so we have to be flexible. But I want to optimize his health before he has the extractions and the surgery. So I have a little cup holder that I've opened. That's a little brass thing, and I screw it into the wall. And then they're all in sequential order. So then I bring it over here, and before I lose them, I staple it right on the side. And then I put Jim's name on there, and that he has 0 appliance. Now, I also then go through and I have a stamp. Dental OSB EKG, not for diagnosis. I never give these things to the patients. I tell them it's not necessary. You don't need it. The doctors don't need it. I need it. And most of the time they back off, because I'm not using this as a cardiac screening device. I'm using it to adjust my appliance. I know there's a lot of fine nuances to that, but I'm doing everything I can to explain to the patient and the doctor that this is not one of these dentists trying to be a doctor. Even though I am, I'm not a medical doctor. He's the medical doctor. That's why I'm deferring to him on everything that the patient's doing. Now what they do and how they get along and all of that stuff is up to them. But I kind of shorten them. You want to put a hole in the top, the hole puncher, bend them over, put a paper clip on it, and just mount it in our chart. The chart's got little wings, wire wings. I just stick it on that and fold it down. So I can see my progress. When I see him next, I'll have an appliance in there. Not only will I see how the appliance affects it, but then I'll adjust the appliance and optimize his EKG, his blood, which has the blood pressure, pulse, and oxygen levels on it. Okay.